Health Watch is presented by UMass Memorial Healthcare. Here, caring for you.
Welcome to Health Watch, presented by UMass Memorial Healthcare. I'm Olivia Lemon. Today's topic is a total knee replacement.
Total knee replacement is now one of the most common operations done in the United States. There are over 1 million knee replacements done annually in the United States of America. This is related to the aging of the baby boomers, as you stated. Baby boomers do not want to live with pain and limited functional ability. They want to have that pain relieved, and they want to continue with the activities that they want to continue with.
What are the components of a total knee replacement?
There are 4 physical components of a knee replacement. And this model shows you a model of a femur or thigh bone, the upper part of the tibia or shin bone. The patella is inside of this tendon. So those are the 3 bones that we're dealing with when doing a knee replacement. The replacement is made of a metal cap that is attached to the end of the femur, a metal tray that's attached to the top of the tibia, and then a polyethylene, ultra-high molecular weight polyethylene spacer that's between the 2 pieces of metal, and a metal button that's attached to the back of the patella. During the operation, the surgeon removes the end of the bone, just the damage that's caused by the arthritis. It's roughly the same thickness as the metal cap. So it's not a large piece of bone, it's a very small piece of bone. And then the end of the femur is shaped, so it's shaped in the same shape as this cap, the metal cap. So the metal cap is then able to fit on the end of the bone, and that's a major part of the replacement. Similarly, on the tibia, the surgeon removes the top piece of the tibia. This is where the damage from the arthritis occurs, and replaces that with a metal tray. The metal tray has a stem that fits inside of the bone, and it's attached very firmly to the top of the tibia. But we don't want metal articulating and rubbing against metal. We want to have a low friction surface in between, and that's what is this ultra-high molecular weight polyethylene, so that when you put this together, you have a metal polyethylene metal sandwich. So there's no way those bones can rub together anymore, which is what happens with advanced arthritis. There's no cushion left, the cartilage is gone, so the bones rub together, causing the severe pain. And this plastic metal sandwich replaces the cartilage, so the bones cannot rub together any longer. The last piece, the 4th piece, is also a polyethylene cap or button that goes on the undersurface of the kneecap. And that is inside this tendon, which slides up and down a groove here in the metal cap as the patient bends and straightens their knee.
Does a knee replacement address other symptoms associated with arthritis?
Many patients with advanced arthritis have either a knock-kneed deformity or a bow-legged deformity, and part of the operation is correcting that deformity so that the leg is straight.
How are today's implants different from those used 10, 20, or even 30 years ago?
These implants have improved dramatically since they were introduced in the late 70s and early 80s. The metal is a alloy that's extremely tough and does not fred metal particles and is attached firmly to the end of the femur. And the plastic is improved dramatically as well. So that with normal use, the expected lifespan of this replacement in a typical patient is often 15 to 20 years.
What physical restrictions are there for knee replacement recipients?
One of the reasons people have this operation is to get rid of the pain, and so it's extremely successful in getting rid of the pain. The second reason is to improve function and to allow people to go back to the activities that they want to do. It allows everyone to go back to walking, hiking, biking, dancing, normal activities of daily life plus small amounts of exercise. People who are particularly motivated and who have, participated in athletic activities before surgery often wish to go back to those. Things like tennis or biking or skiing are fairly common. But if you've never skied, you're probably better off not taking up skiing after you've had your knee replaced. I tell my patients, if you're an expert skier and you are willing to stay on the blue slopes or the green slopes and avoid the double black diamonds and avoid the bumps, and you're going out for an enjoyable social day with your family and perhaps the grandkids, that's acceptable. You need to go at a level, you need to ski at a level where you will not fall.
Have improvements in the implants improved a patient's recovery?
Patients now routinely get out of bed the afternoon of their operation and then an hour or so later get up with a physical therapist and walk in the hall with the aid of crutches or a walker. So people are up and walking the same day as their operation and typically spend one night in the hospital.